Welcome to PGOG Pathways to Growth in Obstetrics and Gynecology for postgraduates and consultants. Today's topic is RH isoimmunization or red cell isoimmunization with a question answer format. I have selected this question answer format mainly the reason is you might get a case in your practical examination of a RH negative pregnancy, and then it is easier to understand what should be the answer for a specific question if we approach the topic as a question answer format. Secondly, this is a commonly asked theory question also you might get, and your concepts are clear, it is easier to answer in theory paper also, and in practice also whenever we get a clinical situation, and if we approach it as if this is the situation, what should be the next step, then it becomes easier in practice also for us to implement whatever knowledge we have gained. Why D antigen is called as a type of rhesus antigen or Rh antigen? It is a historical misnomer actually. Initially, it was thought that human D antigen is same as was found in rhesus monkeys, so it was called as Rh, short for rhesus monkeys. But later on, it was found that it is this D antigen found in the human. It differs from the one which is found in rhesus monkeys, but the Rh system name continued. Now, if we see the recent literature, it mentions Rh as CDE system of blood group and Rh typing. It does blood group typing. It doesn't include it as a Rh typing, but as a CDE system, which includes capital C, small c, capital D, capital E, and small e. Remember that there is no small d in all these types of CDE system where there are various blood group types are there. There is no small d. D, C, and E plus C. That means whenever there are antibodies against E as well as C, these are the common Rh antigens leading to severe alloimmunization. K antigen is also a red blood cell antigen, but it is not a Rh type. And this K antigen also is one of the important cause for the severe alloimmunization. It can also lead to alloimmunization. So that is what I want you to remember, that out of this most common is D, then is small c, not capital C. And if there is a coexistence of E and small c, then E enhances the effect of C, and that is why it is also included as one of the cause which can lead to a severe alloimmunization. Whereas K leads to severe alloimmunization, but it doesn't come under the umbrella of this CDE system. It is a separate RBC antigen. Which red cell antibodies are clinically significant during pregnancy? Anti-D is the red cell antibody, which is most commonly the one which is leading to hemolytic disease of fetus and newborn, HDFN. Previously, the old terminology for this hemolytic disease of fetus and newborn was erythroblastosis fetalis. And less common are, as we have already seen in the previous slide, anti-C, small c, anti-K, anti-E plus C antibodies. RhD antigen, what is it? It is a protein which is present on the surface of red blood cells in Rhd positive individuals. This is what is found in Rhd positive is this is the red blood cell and this is the D antigen which is present over the surface. It is a protein which is present over the surface of the red blood cell. Its absence is Rhd negative status. Now, if we see, it is such a vast subject of blood group systems that there are total 36 blood group systems, 36, and 360 RBC antigens are altogether present, out of which these are the ones which are important for us as obstetricians because these can lead to uh, this HDFN, or these can lead to immunization adversely affecting the fetus and the newborn, and that is why this we should remember only this, but there are total 360. It is such a small cell and it has so many antigens which are present over it, which are capable of producing antigen antibody reaction. Now this anti-D Rh immunoglobulin, it was made available in the market in 1968, so almost 60 years back. So relatively it is a new drug. Now, is this Rh alloimmunization a preventable disease? If you are asked this question, and how is it preventable? So it is a preventable disease by prophylactic administration of anti-Rhd immunoglobulin in the antepartum and postpartum period for correct indications with a correct dose. If it is used with for correct indications with a correct dose, then this Rh alloimmunization can be prevented. So how much is the reduction which has been achieved worldwide with the availability of this Rh for prophylaxis of greater than 50 years now? There is only 50% reduction. Still, there are more than 2 lakh cases of perinatal morbidity and mortality per year are still recorded all over the world. It is almost eradicated in developed countries, but it remains still persistent in less developed countries because in less developed world it is not possible to achieve this prophylaxis for correct indications with a correct dose because of the practical issues which are present in the less developed world. Now, what can lead to Rh immunization? Pregnancy, previous blood transfusion. This history is more common whenever there is a non-Rhd immunization, such as C, small c, or capital E plus C. For these, or for even for the anti-K antibodies also, history of previous blood transfusion plays a greater role as compared to for the D and transplantation. Now, if we see the literature or if we read the textbooks, some of the textbooks mention this Rh as Rh isoimmunization, whereas some other textbooks are mentioning it as alloimmunization, and we do get confused whether these are the same, the meaning is same, or what is the difference between this. If we say Rh isoimmunization, is it correct? Or should we say Rh alloimmunization only? If we go through Williams' textbook of obstetrics, everywhere it is mentioned as alloimmunization. Whereas if we see the guidelines, some of the even guidelines of various countries, there we find that the terminology which is being used is isoimmunization. So alloimmunization is immune response, that is production of antibodies to antigen from other individual of the same species. What is isoimmunization? Isoimmunization is immune response to fetal cells entering into the maternal circulation. Isoimmunization is a type of alloimmunization. So ultimately it is alloimmunization only, but here specifically whenever it is related to mother and the fetus, then we use the terminology as isoimmunization. But remember that ultimately the meaning is same, so both these terms can be used for Rh immunization. Either we can use alloimmunization or isoimmunization. Now, what happens whenever there is a first pregnancy in a Rhd negative woman? Why first pregnancy is less commonly affected as compared to subsequent pregnancies with Rh alloimmunization? Or what is the chance of feto-maternal hemorrhage in pregnancy? Now, what is happening is the fetal RBCs, whenever they positive, Rh positive or D positive RBCs, whenever they enter into the maternal circulation, then only there is an antigen antibody reaction. Now, sensitization can occur with 0.1 ml of fetal RBCs also. And as we can see in this graph, 50% of the antenatal patient will have 0.07 ml of feto-maternal hemorrhage in first trimester. 60% will have 0.08. So as pregnancy progresses, number of women who are having feto-maternal hemorrhage during pregnancy keeps on increasing, 0.13 in third trimester, and maximum at the time of the delivery 0.19. This is one of the data average. How much is the in a normal pregnancy, low risk pregnancy, how much is the feto-maternal hemorrhage, or how much is the fetal blood which is entering into the maternal circulation? And as pregnancy advances, there is increasing percentage of more and more women where there is a passage of fetal blood or fetal RBCs into maternal circulation. So each subsequent pregnancy gets affected more severely, because as with next pregnancy more fetal cells will be entering, more fetal blood will be entering. First pregnancy is least affected. How does RHD alloimmunization or isoimmunization cause hemolytic disease of fetus and newborn? Step 1 is Rh negative woman, and there is a RHD positive partner with a RHD positive fetus. Fetus is Rh positive, woman is Rh negative. Entry of RHD positive fetal RBCs in the maternal circulation through placenta, then IgG and the through placenta, from fetal vessels through placenta, these are fetal RBCs which are RHD positive are entering into the maternal circulation. Purple one are the fetal RBCs and red one are the maternal RBCs. Green is the antibody response. These are anti-RHD IgG antibodies develop into maternal circulation. These IgG antibodies, through placenta transplacentally, they again enter into the fetal circulation and leading to hemolysis of fetal RBCs because of the by these antibodies, leading to fetal anemia and neonatal jaundice as the important complications. That is how this RHD alloimmunization leads to hemolytic disease of fetus and newborn. What is the hemolytic disease of fetus and newborn? There is an immune hemolysis of fetal or and neonatal RBCs by transplacental passage of maternal immunoglobulin G, IgG antibodies. If there are IgM antibodies, the IgM antibodies do not cross the placenta, and that is why these are not harming the fetus, but IgG antibodies do cross. It leads to anemia requiring intrauterine or postnatal transfusion. Severe fetal anemia leads to hydrops associated with polyhydramnios, skin edema, cardiomegaly, and there is a postnatal jaundice and overall increase in perinatal mortality. Most common cause of HDFN is anti-D antibodies. Other causes are anti-K, that is scale antibodies, anti-small c, and as we have already seen, anti-E plus C antibodies, because E will lead to greater impact of anti-C antibodies. It enhances the action of anti-C antibodies. Again, Kale antigen is not a type of rhesus antigen. It doesn't come under the umbrella of rhesus or CDE system. Now, how can this is a very commonly asked question, and it is a one which helps in practice also to us to understand the disease. How can a Rh negative mother and a Rh positive father have a Rh negative baby? Now, a gene RHD is present on short arm of chromosome 1. It is responsible for D positive status. There are two copies of this RHD gene in each individual. Each copy is inherited from each parent. When an individual has two identical genes as capital DD or small dd, a person is homozygous positive or homozygous RHD negative. If these two copies are non-identical, that means capital D small d, then that individual or a person becomes heterozygous. But as D is dominant gene, heterozygous person is always RHD positive. There is a 50% chance that Rh negative mother and heterozygous Rh positive father will have either Rh positive or Rh negative fetus. Here we can understand mother is small d, father is capital D. And what is happening with that capital D, that there is a possibility that the chance is there that father is capital D small d heterozygous, so that there is a possibility, 50% possibility that baby will be Rh negative, or 50% possibility baby will be RHD positive. Capital D indicates presence of gene. Remember, there is no small d as such as a type of blood group system. And small d indicates absence of this RHD gene. That we have to understand here, that small d is not presence of a separate gene. On the other hand, it indicates that there is an absence of gene, and capital D indicates there is a presence of gene. There is no blood group type as a small d. Please remember. Now, what is grandmother effect related to Rh alloimmunization? Rh positive heterozygous mother and Rh negative or Rh positive heterozygous father can have a female baby which is Rh negative. So, mother is positive, baby is negative. Grandmother is positive, mother is negative. On the other hand, it is easier to remember that way. This female baby. Now, immunization with formation of antibodies occurs in this female baby, and when this female becomes adult and carries a Rh positive fetus, it will be exposed to these antibodies which were produced against grandmother's RBCs, and that is why this is called as a grandmother's effect. Grandmother is Rh positive, mother is Rh negative, fetus is Rh positive. Fetus being exposed to antibodies which were created in response to maternal RBCs. That is why it is called as grandmother's effect. What is hydrops and what is the differential diagnosis of hydrops fetalis? That question you might be asked in your practical examination related to Rh negative pregnancy. Hydrops fetalis is excessive accumulation of fluid in the fetal tissues and body cavities. At least two body cavities are involved, which is usually detected by ultrasonography, and it is associated with worsening of the perinatal outcome. Differential diagnosis, we can divide it into immune hydrops and non-immune hydrops. In the immune hydrops, Rh alloimmunization with capital D or small c, anti-K alloimmunization or isoimmunization. ABU incompatibility usually is associated with a severe, not such a severe affection, but rarely it can lead to hydrops and other rare Rh alloimmunizations. In non-immune, fetal cardiovascular abnormalities, infections, genetic abnormalities, structural causes, hematological causes, and twin to twin transfusion syndrome in monozygotic twins can also lead to hydrops changes in the fetus. When should be the blood group and RHD typing of antenatal woman be done? When will you advise? So it should be done at the earliest in first trimester at first antenatal visit, as there might be need to take a decision about the prophylaxis in a high risk situation such as abortion or ectopic pregnancy. What is RHD typing? Why should we mention RHD? Again, now the same thing we have already seen, but in a different format, the question is there. Now, on RBCs, RHD antigen is present. It produces antibodies when these RBCs enter into the circulation of a RHD negative individual. There are other 50 types of Rh antigens on RBCs, which can also produce immune response such as antigen C, small c, or capital E with C. It is necessary to mention RHD for this reason. So it is not only always a D. When you say RH, there are so many others also which might be there, and whenever we use RH, we need to write D. Otherwise, what we see nowadays in the current literature is RH has been removed, and what is written only is D positive, D negative. Then there is no need to then be more specific. But if you are writing RH, you need to be writing D in bracket, capital D in bracket. Diagnosis as only Rh negative pregnancy is incomplete. What should be the immediate next investigation when a pregnant woman's test result shows that she is RHD negative? We need to do the partner's RHD typing. What other investigation you will do if partner is RHD positive? Genotyping of the partner to know whether he is homozygous or heterozygous for RHD gene. Every pregnancy is at risk if he is homozygous. We have already seen if he is heterozygous, 50% possibility of chance is there that baby might be Rh negative also, RHD negative. Fetal self-free DNA testing is an alternative to this genotyping testing of the husband or the partner, because it might be cost effective. Both are genetic tests, and this fetal cell-free fetal DNA testing also has good sensitivity specificity, and we can it is there is we have option either to go ahead with genotyping of the partner, or we can do the fetal cell-free fetal DNA testing. Now, when will you suspect non-anti-D immunization? A woman with a history of hemolytic disease of fetus and newborn in previous pregnancy or present pregnancy, no ABO incompatibility in mother baby, no RHD incompatibility, no history there. History of blood transfusion might be there. History of anemia without hyperbilirubinemia in the previous baby strongly is suggestive of anti-K antibodies, because this what happens is these anti-K antibodies are directly attacking the RBC precursors, erythrocyte precursors in the bone marrow, and that is why there is no hyperbilirubinemia, but there is a severe anemia with a anti-K antibodies. And there are no other causes of non-immune causes of hydrops. Then we can suspect that there is a non-anti-D type of isoimmunization. Test for anti-C, anti-K, anti-C plus anti-E antibodies is mandatory in such a situation. Now, why sensitization is only 16%? It is low in RHD negative women. Even if RHD negative woman carries RHD positive fetus, still in only 16%, around on an average 16% of the patients only RH immunization or sensitization occurs. Less sensitization is because of insufficient transplacental passage of fetal antigen, that is fetal RBCs, as well as maternal antibodies. Then maternal fetal ABO incompatibility protects against RH isoimmunization, because there is a rapid clearance of fetal RBCs before RHD immune response starts. Now, every this fetus will have variable antigenicity, and variable maternal immune response is also seen. These are the reasons why the sensitization is low in RHD negative women. Can we know fetal RHD typing in early pregnancy? If this question is asked, your answer should be yes by non-invasive cell-free fetal DNA. It is written as cfDNA or ffDNA. Some of the textbooks are using short form as ff. That is fetal free DNA, or CF is cell-free DNA testing. Genotyping by PCR is done. It can be done from 16 week onwards for RHD detection, and from 20 weeks onwards for anti-K antibody detection. It's antigen detection. I'm sorry, it detects the antigen because we are doing it on the fetal DNA. Advantages are greater than 95% sensitivity specificity. It is non-invasive. It avoids unnecessary antenatal prophylaxis. Suppose a patient, so you do it and you know that a baby is Rh negative. Mother is also negative. There is no need to consider antenatal prophylaxis. Tests for D, C, E, and K antigen detection can be done as per maternal antibody detection. Disadvantages are high cost, low availability. So cost effectivity is always an issue with this test at present. And in dizygotic twins, it cannot differentiate which fetus is involved. Now, for this same indication, previously amniocentesis was done, but it is no more being done for this indication, as wherever facilities are available, this non-invasive cell-free fetal DNA testing is preferred over amniocentesis. So, what is the place of this cell-free DNA or fetal free DNA testing in fetal RHD status detection? If it is positive, if there is a positive indirect Coombs test because of the previous pregnancy exposure, but present fetus might be D negative, especially if the partner is heterozygous. So if the report comes as negative cell-free DNA, there is no need of anemia surveillance. There is no need for even serial ICT also. Indirect Coombs test, or repeated middle cerebral artery Doppler is not required, and there is no need of antenatal prophylaxis. These are the advantages of doing this cell-free fetal DNA testing whenever the indirect Coombs test is positive. What we want to know is it might be positive because of the previous exposure, previous pregnancy or any other exposure, previous blood transfusion. And baby, if baby turns out to be D negative by this test, we can avoid this serial ICT, serial fetal Doppler and antenatal prophylaxis. If there is a negative indirect Coombs test, then and if the cell-free fetal DNA also turns out to be negative, there is no need of antenatal prophylaxis. But cost effectivity here is an issue. Cost of this test versus cost of antenatal prophylaxis. Antenatal prophylaxis is cheaper as compared to this cell-free fetal DNA testing, and so at present it is not recommended by ACOG guideline. There is a difference in the guideline in ACOG and NICE guideline on this point, that if it is negative indirect Coombs test, then whether to proceed with the cell-free fetal DNA or not. On this point, there is a difference in the of opinion in the guidelines at present. What is the difference in Rh sensitization and immunization? There is no difference. Both indicate development of antibodies against Rh antigen, and that is the reason these terminologies are used interchangeably in the literature. In how many percent of Rh negative women with ABO compatible Rh positive baby, sensitization occurs without prophylaxis? It occurs in around 16%. 2% by the time the baby delivers, 7% in postpartum period, that is related to first pregnancy, and another 7% will be in the subsequent pregnancy. How much is the risk of sensitization with only postpartum prophylaxis? It is about 1.5%. So from 16%, it drops down drastically only with the postpartum prophylaxis to 1.5%, but still it remains persistent. The risk remains persistent, and that is the reason there is a role of antepartum prophylaxis. The risk reduces to 0.5% whenever we combine antenatal prophylaxis along with postnatal prophylaxis. How will you do postpartum prophylaxis? Now, for this question, the answer which is expected is correct dose. So, intramuscularly, we can give 300 microgram or 1500 international unit of anti-RHD immunoglobulin within 72 hours of delivery at the earliest. Intramuscular is as effective as intravenous, but usually we prefer intramuscular because of the risk of sometimes we have a fear of anaphylactic reaction with any intravenous administration. If a patient has got thrombocytopenia or there is a contraindication for intramuscular administration, then intravenous administration can be given in that rare situation. How much Rh positive fetal whole blood will be neutralized by this dose? 30 ml of fetal whole blood or 15 ml of fetal RBCs are getting neutralized with this dose. Which test will measure the actual amount of fetal-maternal hemorrhage at the time of delivery or throughout the pregnancy? It is Klehor-Betke test. And second test, which is emerging now, which is a better test with a greater reliability, is flow cytometry. Something about this Klehor-Betke or KB test or acid illusion test. It measures fetal-maternal hemorrhage. Fetal RBCs contain hemoglobin F, which is more resistant to acid illusion as compared to hemoglobin A. After staining and exposure to acid, fetal RBCs stand out. Maternal RBCs look like ghost cells. Fetal blood in maternal circulation, there is a formula: maternal blood volume multiplied by maternal hematocrit multiplied by percentage of fetal cells in a given slide divided by fetal hematocrit. Now, this Klehor-Betke test is not accurate in maternal hemoglobinopathies associated with high hemoglobin F. Alternative test is flow cytometry, which is more accurate but not routinely available at present in many of the hospitals. What are the events increasing fetal-maternal hemorrhage? Manual removal of placenta, need for the manual removal of placenta, lower segment cesarean section as compared to a vaginal delivery, multifetal pregnancy, fetal demise, and abruptio placentae. These are the cases where there is a possibility of more fetal-maternal hemorrhage even greater than 30 ml And in these such situations, there is a specific indication to proceed with this Kleber test or with the flow cytometry to know exact how much is the maternal feto-maternal hemorrhage, and accordingly give the um, this RH anti-RHD immunoprophylaxis. How is the antenatal Rh immunization prophylaxis done? Antenatal. Single dose can be given as 300 microgram or 1500 international units at from 28 to 34 weeks. Or two doses are given, same dose at 28 weeks first dose and 30 to 32 weeks second dose. Now this is needs to be given unless a woman is already, since this is given and one dose or two doses are given, and if already sensitized woman is there, then this should not be given. Already sensitized is already RH isoimmunization has taken place, RHD immunization has taken place, and then there is no role of prophylaxis. Remember, if indirect Coombs test comes positive and titer is significant greater than 4, there is no role of giving this antenatal or postnatal prophylaxis. How will you know whether a woman is already sensitized for Rh immunization? By doing a indirect Coombs test. If it comes positive, then we know it. How does anti-RHD prophylaxis act in prevention of Rh isoimmunization? Exact mechanism is not known, but it leads to immunosuppression in the mother. What is the role of Rh prophylaxis in cases of miscarriage and in cases of vesicular mole? Now, there is a risk of sensitization is low in spontaneous abortion of less than 10 weeks. It should be given whenever there is a medical abortion or spontaneous abortion of greater than 10 weeks. Prophylaxis should be given. It should be given in surgical abortion irrespective of gestational age. Dose might be reduced to 100 microgram or 500 international units, but if this dose is not available, then the full dose of 300 microgram or 1500 international units needs to be given. In a complete mole, there is no need of giving anti-immunoprophylaxis as there is no organogenesis, but partial mole it is needed. And whenever there is a doubt about whether it is a partial or complete mole, or if we are dependent on histopathology report, it takes more time for the histopathology report to come. And so it is advisable in such a situation to give the anti-immunoprophylaxis. Now, what is the role in ectopic pregnancy? There is a definite role, as risk of sensitization in ruptured ectopic pregnancy is 24%. Dose which is used, it might be a lower dose, might be used as 500 international units or 100 microgram. Chorion villus sampling or amniocentesis, what is the role? Sufficient evidence is not there at present, but it is given in most countries. It is not given in Denmark. Chances of having one positive case are after consecutive 900 cases, and on that basis, it is not given in Denmark. But if you see the FIGO guideline, then it might be given, it comes as a low priority. Bleeding and abdominal trauma in pregnancy, usually it is recommended, though clear evidence is lacking. Full dose is given as 300 microgram or 1500 international units in the second half of pregnancy. If there are recurrent episodes, the dose needs to be repeated after a gap of 3 weeks. A recurrent hemorrhage is there, antepartum hemorrhage. Then if the previous dose has been given and the gap is of greater than 3 weeks, then the dose needs to be repeated. In case of intrauterine fetal death, prophylaxis is indicated. Chances of fetal-maternal hemorrhage are high. Kleber test is to be done in all cases, irrespective of Rh typing. Even in intrauterine fetal demise, where the patient is Rh positive, Then also Kleber-Betke test is recommended to know how much is the fetal-maternal hemorrhage or whether it is a cause of this intrauterine demise. So it is done to identify the cause of fetal demise and to determine the dose of Rh negative dose in Rh negative women. In external cephalic version in a breech presentation, risk is 2 to 6%. Prophylaxis is indicated. If it is already the prophylaxis, routine antenatal prophylaxis has already been done at 32 weeks, then there is no need to repeat the dose. What are the principles of management in the case of Rh negative pregnancy? When there is a Rh negative mother with a Rh positive partner, indirect Coombs test is to be done at first antenatal visit, irrespective of husband's status. If indirect Coombs is positive and if it is feasible to do cell-free fetal DNA, it should be done. If positive ICT is there, then titer needs to be repeated, and it needs to be repeated every 2 weeks till 28 weeks of pregnancy and weekly thereafter. If it is a critical level titer, then fetal Doppler MCA PSV, middle cerebral artery peak systolic velocity is indicated to diagnose fetal anemia. If MCA PSV is raised, it is an indication to proceed with fetal blood sampling and SOS, or if required, intrauterine blood transfusion. Timely termination will be indicated in such cases, and proper neonatal care will be of utmost importance to prevent perinatal mortality. If ICT is negative, it is repeated at 28 weeks, but there is no need to repeat it once if it comes negative at 28 weeks. We should consider antenatal prophylaxis depending on the availability of the anti-RHD immunoglobulin. Prophylaxis needs to be given in all the high risk situations in second half of pregnancy. Postpartum cord blood test is done and postpartum prophylaxis is mandatory. So these are, if you are asked what are the principles or what is this is in short, it is a summarization of the management guidelines or the various management options in a case of Rh negative pregnancy, or principles how we manage a Rh negative pregnancy. Every line is equally important. ICT plays important role. Fetal Doppler MCA PSP plays important role. Then indications and facilities to do proceed with fetal blood sampling and intrauterine transfusion is of importance. Severe Rh alloimmunization before 20 weeks. In such a situation, now there is emerging role of intravenous maternal immunoglobulin therapy. It will delay the need for intrauterine transfusion. And in ICT negative pregnancy, we need to proceed by repeating the test at 28 weeks, and antenatal prophylaxis, if feasible, it should be given. In high risk situations, prophylaxis, high risk situations, high risk for fetal-maternal hemorrhage. Postpartum cord blood test to be done, and postpartum prophylaxis is mandatory. What is the difference between indirect and direct Coombs test? Indirect Coombs test detects anti-RHD antibodies in maternal serum. What is done is maternal serum is mixed with O positive RBCs and Coombs serum. If agglutination occurs, it indicates that there is a Rh alloimmunization is already present. Whereas direct Coombs test, it detects RHD antibodies directly attached to fetal RBCs. There is no need of adding this O positive RBCs here. Cord blood, direct Coombs test, cord blood is taken. It is and washed RBCs are taken. These are mixed with Coombs serum. If there is agglutination, it indicates that Rh alloimmunization has taken place. Same thing pictorially we can see here. Maternal serum with anti-D antibodies are present. We are adding RBCs with D antigen so that these antibodies are attached to these RBCs. Then we are adding Coombs serum containing anti-human antibodies, and that will lead to the agglutination of RBCs in indirect Coombs test. Directly already there are fetal RBCs are there with anti-D antibodies. Coombs serum is added. Agglutination indicates that Rh isoimmunization has taken place. How to differentiate between passive and immune antibodies when ICT comes positive after giving prophylactic anti-D antenatal. Now, guidelines say that whenever we give antenatal anti-D, there is no need to repeat indirect Coombs test. But if it is repeated and the report comes and there is a confusion, then remember that antenatal anti-D immunoglobulin itself can lead to positive ICT because of the development of passive antibodies, but usually the titer remains less than 4 international units per ml. Titer greater than 4 international units per ml and rising titer trend indicates Rh allo immunization. Why ICT is repeated at 28 weeks, even if it is negative in early pregnancy? Now, the already we have seen this, but it is another way of asking the same question to clear the concepts. Fetal-maternal hemorrhage can occur with greater quantity with advancing pregnancy. Antepartum hemorrhage, abdominal trauma, external cephalic version, stillbirth are the high risk situations, increasing the risk of fetal-maternal hemorrhage. ICT might come positive at 28 weeks, and so it needs to be repeated. What are the various RBC antibodies significant titers for HDFN, hemolytic disease of fetus and newborn? For anti-D antibodies, these are the this is the D antigen and these are the anti-D antibodies here. Fetal RBCs with D antigen is there and these are the anti-D antibodies. Titer greater than 4 international units per ml indicates moderate risk of hemolytic disease of fetus and newborn, whereas greater than 15 international units per ml indicates severe risk of HDFN. Anti-C antibodies greater than 7.5 international units per ml indicates moderate risk and greater than 20 international units per ml indicates severe risk. Anti-K antibodies, irrespective of the titer, there can be severe HDFM. Severe fetal anemia can occur because, as I have already said in the previous slide, anti-K antibodies destroy RBC precursors in the bone marrow, and that is the reason there can be severe anemia even with a low titer of anti-K antibodies. Whenever there is a combination of anti-E and anti-C antibodies, even with low titer also, there can be a severe HDFN. As you can see here, yellow ones and the green ones. Green ones are these C antigens and yellow ones are capital E antigens. And if there is a combination of these two, even with a lower titer also, irrespective of the titer, there is a risk of severe hemolytic disease of fetus and newborn. Now, if the indirect Coombs test comes positive, what should be done? Specific antibodies are to be identified, whether it is because of D, small c, or K. To see whether IgG or IgM type of antibody is present. IgM is present, it does not cross the placenta, there is no adverse effect on the fetus. If it is IgG, there is a risk of hemolytic disease of fetus and newborn. We have to then quantify the titer of IgG antibody. The test is to be repeated every 2 weeks till 28 weeks and then on the weekly basis it needs to be repeated. If feasible, cell-free fetal DNA testing to be done after 16 weeks, and if it turns out to be Rh negative fetus, there is no need of further ICT monitoring. Critical titer above which high risk fetal anemia develops, we have already seen in previous slide for this antibody titer of greater than 4 indicates moderate risk and greater than 15 indicates severe risk of hemolytic disease of fetus and newborn. If that critical titer is observed, it is an indication now to proceed with serial fetal Doppler with middle cerebral artery peak systolic velocity test. No need of anti-D RHD prophylaxis if indirect Coombs or direct Coombs test is positive. Remember, this is important practical point. Now, is there a place of amniocentesis in Rh negative pregnancy? There are two scenarios. Amniocentesis for fetal genetic testing was previously done by doing PCR, polymerase chain reaction on amniotic cells, when ICT is positive to know whether fetus is D positive or negative. Now this has been replaced by non-invasive cell-free fetal DNA testing wherever feasible. Chorion villus sampling is contraindicated with high risk of feto-maternal leak, so amniocentesis was previously performed. Amniocentesis, second scenario is amniocentesis to diagnose fetal hyperbilirubinemia in late pregnancy. This has been completely replaced now by fetal Doppler MCA-PSV as a non-invasive test. So you can say that there is a very limited role of amniocentesis in present day obstetrics in the management of Rh negative pregnancy. What is the role of fetal Doppler study in Rh immunization? In pregnancies with positive and critical titer of indirect Coombs test, ultrasonography monitoring with middle cerebral artery peak systolic velocity is to be done every week. It detects fetal anemia. Blood preferentially is shunted to the brain with fetal anemia, and that is why there is increase in this peak systolic velocity of the middle cerebral artery. Increase in middle cerebral artery peak systolic velocity because of increase in fetal cardiac output and reduction in blood viscosity. What is the place of this in Rh immunization? With rising titer, indirect Coombs test titer, MCA PSV has important role. It is repeated on weekly basis. It is when it is greater than 1.5 MOM, multiples of median for that gestational age, it is suggestive of fetal anemia. It detects fetal anemia with 100% sensitivity and 12% false positive rate. It has reduced sensitivity after 36 weeks of pregnancy. And another important thing is it needs to be done by an expert. Abnormal MCA-PSV is an indication for fetal blood sampling and intrauterine transfusion. Intrapartum management, whether RHD negative status affects the mode, place, and timing of delivery. Mode of delivery is not affected except continuous use of continuous electronic fetal monitoring, as it is considered as a high risk pregnancy. Place of delivery, it is to be done at a place with adequate neonatal facilities and blood transfusion facilities are to be available. Timing of delivery is as per the level of antibody titer, rate of titer rise, and whether the fetus has required any fetal therapy such as intrauterine transfusion is needed. When intrauterine transfusion is given, usually the pregnancy is terminated after 1 to 2 weeks because there will be again recurrence of fetal anemia otherwise. Usually the termination is indicated at 37 to 38 weeks. In severely affected pregnancies, depending on the titer and depending on the need of intrauterine blood transfusion therapy, we have to decide the timing of termination. In a low risk Rh negative pregnancy, usually termination is indicated at 37 to 38 weeks of pregnancy. What are the indications for intrauterine fetal transfusion? MCA-PSV greater than 1.5 MOM for gestational age, or presence of hydrops because of fetal anemia where the hematocrit is less than 30%, gestational age less than 34 weeks, because beyond 34 weeks it is the risk of intrauterine transfusion procedure related is greater, and in such a case termination of pregnancy will be a safer option. So usually 34 to 30, before 34 to 35 weeks only this intrauterine transfusion is considered. Usually intravenous transfusion is done through umbilical vein, but if it is required in early second trimester, it is not possible to because it is very thin umbilical vein, then intraperitoneal transfusion is given, or sometimes combination of intraperitoneal with umbilical intravenous transfusion is used. Which blood group typing is to be selected for intrauterine transfusion in case of fetal anemia? Blood group O, or if the fetal blood group is known, then same ABO group with Rh negative blood, which is cytomegalovirus negative, leukocyte deficient. Plasma is reduced to increase the hematocrit to around 80% to prevent the fetal problem because of the overperfusion, and it is irradiated to prevent graft versus host reaction. So irradiation is necessary to prevent the graft versus host reaction. These are the prerequisites. Which tests are to be done on cord blood in a RHD negative woman? blood group and Rh typing, direct antiglobulin test, hemoglobin and bilirubin. Positive direct antiglobulin test indicates fetal RBCs are already coated with maternal antibodies, but it cannot predict how much will be the severity of HDFN. Direct antiglobulin test is negative in ABO induced this hemolytic disease of fetus and newborn. There is no role of anti-RHD immunoglobulin prophylaxis if the direct antiglobulin test, direct Coombs test comes positive. Which blood you will transfuse in Rh negative woman? Same ABO group, Rh negative, K negative, cytomegalovirus negative blood should be transfused. Now remember that in emergency, if it is not available, then we might have to transfuse a Rh positive blood also as a life-saving measure. Now there are FIGO. FIGO is International Federation of Obstetrics and Gynecology. The recommendations for prevention of RHD immunization as per the priority. It has been recommended in 2020. High priority is at least postpartum prophylaxis is to be done. Testing of all women for Rh typing in early pregnancy, testing of the newborn by testing the umbilical cord blood, Rh negative mother, Rh positive newborn, anti-D prophylaxis to be given within 72 hours in non-sensitized women. It can be given up to 10 days if missed in first 72 hours. Dose can be either 100 microgram or 500 international units, but 300 microgram or 1500 international units is the adequate dose. So if it is not available, then only lower dose can be given. Intramuscular is as effective as intravenous route. Now remember that many countries are not able to fulfill this high priority requirement also at present. So unfortunately, even this 100 microgram dose single postpartum prophylaxis is also not feasible all over the world, especially in less developed countries. Middle priority is for antenatal prophylaxis as a routine and in certain high risk events, such as routine antenatal prophylaxis, single dose at 20 to 34 weeks, full dose. Then 100 microgram whenever early pregnancy, surgical abortion, ectopic pregnancy, or spontaneous or medical abortion of greater than 10 weeks. Second half of pregnancy, if there is antepartum hemorrhage, abdominal trauma, or if there is a fetal demise in second or third trimester, then either full dose to be given or not available, then 100 this 100 to 300 or 500 to 1500. That means ideal is to give full dose 300 microgram, not feasible 100 microgram is to be given. Low priority will be less risk of fetal-maternal hemorrhage, anti-D prophylaxis after amniocentesis, chorion villus sampling, external cephalic version, lower dose can be given. So this is especially FIGO has given this, that at least all over the world, if high priority is also implemented, there will be drastic reduction in this Rh isoimmunization. Special situations, whether ART increases the risk of Rh immunization, no. Whether invasive antenatal procedures are contraindicated in a sensitized woman, no. Whether postpartum anti-D prophylaxis should be given if tubal ligation is being done, yes, still it should be done, that because she might go for recanalization later on. Neonatal management, close monitoring for anemia and jaundice, adequate breastfeeding to avoid dehydration because dehydration worsens jaundice, and adequate neonatal facilities are to. Thank you so much. References are I have taken from Williams Obstetrics 2019. Then there is a nice green top guideline 2014, which makes it quite clear wherever facilities are available, what is at present is being done in the developed world. FOXY guideline mainly to prioritize and a high priority, middle priority, low priority, and accordingly prevention of this Rh immunization all over the world. This FOXY guideline is important. I'm sorry, this FIGO guideline is important, and FOXY is for Federation of Obstetrics of India. That also helped me a lot in preparing this topic. Thank you once again.